Good morning to all. Today's topic is on antimicrobial therapy, which includes systemic antibiotics and local drug delivery. Learning outcomes are explain the recommended antibiotic regime for preventing infective endocarditis, specify the various antimicrobial agents used in the management of periodontitis cases, prescription writing of an antimicrobial agent, discuss the necessity for local drug delivery agents or sustained and controlled release drugs, categorize LDD, local drug delivery agents, and mention the ideal properties of LDD agents. Explain the various indications and contraindications of local drug delivery agents. Specify local drug delivery agents used in treating periodontitis. List the benefits of LDD. So, coming to the introduction part, it's well established that various periodontal diseases are caused by bacterial infection. So over the time, the plaque biofilm that is formed becomes more complex and which leads to the succession of bacteria so that are more pathogenic. So this complex biofilm now offer some protection from the host immunological mechanisms in the periodontal pocket as well as from antibiotics used for the treatment. And it has been suggested that an antibiotic strength that is 500 times greater than the usual therapeutic dose may be needed to be effective against the bacteria that have arranged in biofilms. So it is well understood that this mechanical removal includes manual instrumentation, and these procedures are considered as anti-infective therapy. That is to treat periodontal pockets by mechanically removing local factors and by disrupting the subgingival plaque biofilm itself. So many chemotherapeutic agents are also now available. There is to the clinicians who treat periodontal diseases. There is systemic anti-infective therapy and local and anti-infective therapy that is placing directly into the periodontal pocket. Systemic that is orally taking. So this can reduce the bacterial challenge to the periodontium. So it's also possible that systemically administered NSAIDs may play a role in future adjunctive therapy. So there is this chemotherapeutic agents can also modulate the host immune response to bacteria and reduce the host self-destructive immunological response to bacterial pathogens. Thereby, it can reduce the bone loss. So coming to the details of each, coming to the definitions, what is an anti-infective agent? What is an antibiotic? What is antiseptic? What is disinfectant? So, an anti-infective agent is a chemotherapeutic agent that acts by reducing the number of bacteria present. Antibiotic is a naturally occurring semi-synthetic or synthetic type of anti-infective agent that destroys or inhibits the growth of select organisms, generally at lower concentrations. So this there can be bacteriostatic or bactericidal antibiotics. So bacteriostatics, example tetracycline, clindamycin, and bactericidal can be penicillin and metronidazole. So coming to antiseptic, that is a chemical antimicrobial agent that can be applied topically or subgingivally to mucous membranes, wounds, or indirect dermal surfaces to destroy microorganisms and inhibit their reproduction or metabolism. For example, active ingredients in oral rinses and dentifrices. Then coming to disinfectants, there is a subcategory of antiseptics. They are antimicrobial agents that are generally applied to inanimate surfaces to destroy microorganisms. Next is antibiotic regime for preventing infective endocarditis. So what is infective endocarditis? Is an infection caused by bacteria that enter the bloodstream and settle in the heart lining, a heart valve or a blood vessel. So which is very uncommon, but people with some heart conditions have a greater risk of developing it, and which was first suggested by Levison Grant in 1923. So, what are the indications for developing for indications for antibiotic prophylaxis? That is, those who are very risky in developing the infective candidiasis. That is, the patients with prosthetic cardiac valves or prosthetic material. That is, with transcatheter implanted prosthetic valves, angioplasty, left ventricular assist devices, or implantable heart, congenital heart diseases, previous relapse or recurrent infective endocarditis, cardiac transplant recipients who develop cardiac valvulopathy. So these are the indications for antibiotic prophylaxis by latest update by American Heart Association (AHA), and they've given that some of the invasive dental procedures that need antibiotic prophylaxis, but it is not recommended following exfoliation of primary teeth or trauma to the lips or oral mucosa. So this is the antibiotic regime given. That is for the patient group those who are able to take oral medication, amoxicillin 2 gram, that is 30 to 60 minutes before the procedure. Those who are unable to take oral medication, ampicillin 2 gram IM or IV, cefazolin or ceftriaxone 1 gram IM or IV. Those who are allergic to penicillin or ampicillin and able to take oral medication, cephalexin or clindamycin, vastromycin or clarithromycin. The dosage is being given here. And those who are allergic to penicillins or ampicillin and unable to take oral medication, that is cefazolin and ceftriaxone, 1 gram IM or IV, or clindamycin 600 milligram IM or IV. Okay, so there will be different dosage for children. So systemic administration of antibiotics. So the treatment of periodontal diseases is based on their infectious nature. So it is always advantageous to administer the antibiotics as an adjunct to SRP. So an ideal antibiotic for use in the uh, prevention and treatment of periodontitis should be specific for periodontal pathogens, should be allergenic, should be non-toxic, should be substantive, not in general use for the treatment of the disease, and should be inexpensive. So, although this appears simple, the difficulty lies primarily in identifying the specific etiological microorganisms. There should be identified based on antibiotic sensitivity test. So, these are some of the antibiotics used to treat periodontal diseases. There is penicillin, under that amoxicillin, and there is extended spectrum of antimicrobial activity, excellent oral absorption used systemically. Then coming the augmentin, there is the effective agonist penicillase producing organism, microorganism used systemically. And tetracycline, there is minocycline, doxycycline, tetracycline. They are broad spectrum of microorganisms used both systemically and used locally. Tetracycline also broad spectrum, and it can be used systemically or locally. So this chemotherapy used in and sub-antimicrobial doses for host modulation. There is periostat, effective agonist, a broad spectrum of microorganisms. Coming to quinolone group, ciprofloxacin, there is effective agonist gram-negative rods, promotes health-associated microflora. And macrolide, there is the azithromycin, concentrates at sites of inflammation used systemically. Lingomycin derivative, clindamycin, used in penicillin allergic patient, effective anaerobic bacteria, used systemically. And nitroimidazole, there is metronidazole is coming under that group. And effective anaerobic bacteria used systemically and applied locally as gel. So coming to the penicillin, the main indication, as we told, that is a broad spectrum. So it can be used against localized aggressive periodontitis, generalized aggressive periodontitis, and also refractory periodontitis. And sometimes, like not a single antibiotic is more effective. The combination will be more. So there is the augmentin. There is a combination of amoxicillin and clavulanate, potassium. And coming to the metronidazole group, it is mainly indicated that is against the anaerobic bacteria. So it's used in localized aggressive periodontitis, generalized aggressive periodontitis, refractory periodontitis, as well as for necrotizing ulcerative periodontitis. So, although oral bacteria are susceptible to many antibiotics, no single antibiotic and the concentration achieved in body fluids inhibits all putative periodontal pathogens. So, indeed, a combination of antibiotics may be necessary to eliminate all putative pathogens for some periodontal purpose. So these regimens are prescribed after a review of patient's medical history, patient periodontal diagnosis, and antimicrobial testing. So, the treatment of an individual patient must be based on patient's clinical status, the nature of the colonizing bacteria, and the ability of the agent to reach the site of infection and the risk and benefits associated with the proposed treatment plan. So the clinician will be purely responsible for choosing the correct antimicrobial agent. So this is the regimen that can be used to treat periodontal diseases. So we have given the dosage and the drug names, and so you can go through it. There is amoxicillin 500 milligram 3 times daily for 8 days, azithromycin, ciprofloxacin, clindamycin, doxycycline or minocycline, metronidazole 500 mg 3 times daily for 8 days, and combination. As we told, there is metronidazole and amoxicillin, and metronidazole and ciprofloxacin. So, no consensus exists regarding the magnitude of risk for the development of bacterial resistance. The common and indiscriminate use of antibiotics worldwide has contributed to increase in numbers of resistant bacterial strains since the last 1990s, and so this trend is likely to continue given the widespread of antibiotics. The overuse, misuse, and widespread prophylactic application of anti-infective drugs are some of the factors that have led to the emergence of resistant microorganisms. So, this increasing level of this resistance of the subgingival microflora to antibiotics have been correlated with the increased use of antibiotics in individual countries. So, always it is recommended to have antibiotic sensitivity test before prescribing antibiotics. And also, researchers they have noted that the subgingival microflora tends to revert to the similar proportions of antibiotic resistant isolates 3 months after the therapy. So, coming to each antibiotic group, tetracyclines have been widely used for the treatment of periodontal diseases, and it is a group of antibiotics that are produced naturally from certain species of streptomyces or derived synthetically. So, tetracycline is a group of bacteriostatic that is widely used for the treatment of periodontal diseases, and it is mainly act against aggregated bacteria actinomyces comitans, that is A, that is mainly used for treating localized aggressive periodontitis and refractory periodontitis. It also has an anti-collagenase effect that leads to bone regeneration, and their concentration also in gingival crevice is 2 to 10 times than that found in serum. And also this tetracycline, minocycline, doxycycline are some of the members, there is semisynthetic members of the tetracycline group that have been used in periodontal therapy. So coming to the dosage, there is tetracycline 250 milligram 4 times daily, and minocycline 200 milligram per day for 1 week, and doxycycline 100 milligram twice daily for the first day, which is then reduced to 100 milligram daily. So coming to minocycline, it is a broad spectrum antibiotics, and it is act against spirochetes and motile rods. And coming to doxycycline, it has the same spectrum of activity as minocycline and can be equally effective. So then coming to the metronidazole, it is bactericidal to the anaerobic microorganisms, especially against Porphyria gingivalis and Periodontitis intermedia, and it is used to treat anachronic periodontitis and aggressive periodontitis by disrupting the bacterial DNA synthesis in condition with a low reduction potential. Coming to the dosage, that is 250 milligram 3 times daily for 7 days. So it can be used in combination with amoxicillin or augmentin, and metronidazole may be more value for the management of patients with refractory periodontitis or localized aggressive periodontitis. Coming to penicillins, penicillins are a drug of choice for the treatment of many various infections in humans. And penicillins, other than amoxicillin and amoxicillin clavuline potassium, have not been shown to increase periodontal attachment levels. So these are widely used antibiotics, and they inhibit bacterial cell production, and therefore they are bactericidal. And mainly coming to the amoxicillin, it is a semisynthetic penicillin with an extended anti-infective spectrum, which includes gram-positive and gram-negative or bacteria. So this is mainly used for the management of patients with aggressive periodontitis in both localized and generalized forms, and the recommended dosage is 500 milligram 3 times daily for 8 days. Since amoxicillin is very susceptible to penicillase, which is beta-lactamase enzyme produced by certain bacteria that breaks the penicillin ring structure and thus renders penicillins ineffective. So then coming to the combination, there is amoxicillin clavonate potassium or augmented. So that makes this an anti-infective agent resistance to the penicillase enzyme produced by some bacteria. So this may be useful for the management of patients with LAP or refractory periodontitis and which lead to arrested alveolar bone loss. And and also in patients with refractory periodontitis. Okay. So then coming to the cephalosporins, so those there is the family of beta lactams known as cephalosporins. So they are resistant to a number of beta lactamases. They are normally active against penicillin, so they are not used to treat dental related infections. So there is the cephalosporin. So those who have an allergy to penicillin may also have an adverse reaction to cephalosporins. So coming to clindamycin, this is effective against anaerobic bacteria and has a strong affinity for osseous tissue, and this helps stabilize refractory patients. And the dosage coming like 300 milligram twice daily for 8 days, and when needed. However, clindamycin can be used with caution, but it is not indicated for patients with history of colitis. So the diarrhea, cramping that develops during clindamycin therapy may be indicative of colitis, so it should be discontinued. So coming to the ciprofloxacin, there is active against gram-negative rods, including all facultative and some anaerobic putative periodontal pathogens. So there is only antibiotics in periodontal therapy to which all strains of AA are susceptible. So there is a demonstrate a minimal effect on streptococcus species which are associated with periodontal health also. So there is it can be used in combination with metronidazole for a better effect, and and also it has been reported to enhance the effects of warfarin and other anticoagulants. Same like metronidazole, also it interferes with warfarin. Same like that, ciprofloxacin also enhance the effects of warfarin. So those patients who are taking warfarin or any other anticoagulant not advised to take ciprofloxacin or metronidazole. So coming to the macrolides, they inhibit protein synthesis by binding to 50S ribosomal subunits of sensitive microorganisms. And this can be bacteriostatic or bactericidal depending on the concentration of the drug and the nature of the organism. So which include erythromycin, spiromycin, and azithromycin. Out of this azithromycin is the only member, there is the only antibiotic that has effect on periodontitis. There is its concentration is significantly higher than that of normal gingiva and effective adjunctive therapy for increasing attachment levels in patients with aggressive periodontitis. So it has been found that it is actively transported to the sites of inflammation by phagocytes. So where it is released directly into sites of inflammation as the phagocytes rupture during phagocytosis. So, and it's coming to the dosage, it's like 250 milligram per day for 5 days after an initial dose of 500 milligram. So then coming to there is combination antibiotic therapy. We have so many combinations. There is periodontal infections may contain a wide variety of bacteria. So no single antibiotics is effective against all putative pathogens. So always there is the combinations of antibiotics are used against the periodontal. So there is antibodies that are bacteriostatic generally require rapidly recurring organisms to be effective. They do not function well if a bactericidal antibiotic is given concurrently. For example, it's not advisable to give like retrocycline along with amoxicillin. Since retrocycline is bacteriostatic and the amoxicillin is bactericidal. So these are some of the antibiotic agents that can be used for periodontal diseases. There is or in both cases it is advised to go for the antibiotics. There is first one, there is gingival diseases. Usually for gingival diseases it is not recommended. Antibiotic disease is not recommended. So it's just the scaling and root planing. So next, coming to the necrotizing ulcerative gingivitis, there is antibiotic use not recommended unless there are any systemic complications. So if it is in any systemic complications, then it is recommended. Then coming to the chronic periodontitis, there is limited benefit. That is antibiotic use not recommended. There is usually chronic periodontitis is associated with the slow progression of disease. So usually it is recommended to have like other mechanical ways of therapy. So coming to aggressive periodontitis, it is more of host modulation or more of bacterial influence in case of aggressive periodontitis, for example AA. So antibiotic use recommended for greatest benefit. Therapeutic levels of antibiotic should be achieved by the time scaling and obtaining are completed. All debridement should be completed within a week, and then the optimal antibiotic type, dose, frequency, and duration have been identified. So it's as an adjunct to the therapy. Okay. So coming to the necrotizing ulcerative periodontitis, so there is antibiotic use dependent on the systemic condition. Again, it's depending on the systemic condition of the patient. So it always is an adjunct when it is necessary. So periodontitis as a manifestation of systemic disease. If it is occurring as a manifestation, there is usually in every patient. It can occur as multiple periodontal abscess. So this antibiotic is dependent. This also it is mainly dependent upon the systemic condition of the patient as an adjunct when necessary. So and then coming to the periodontal abscess, actually antibiotic use not recommended now. It's not applicable. So these are the therapeutic uses of the antibiotics or systemic antibacterial agents for various periodontal diseases. So this is just a decision tree for the selection of antibiotic therapy. So when you are getting a case like all these cases, you can either go to SRP, and if it is not a resolution, like not solving, then you can go for a surgery or you can try for the antibiotics. So under antibiotics, it can be either local drug delivery or uh, local and systemic antibiotics or systemic antibiotics. So under local drug delivery can be resolution or nursing resolution, and non resolution can be surgery to systemic, and again it coming to resolution and non-resolution surgery. The same way, if it is systemic antibiotics, if it is a resolution, non-resolution, going to local drug delivery, and then resolution and non-resolution to surgery. And with the local and systemic antibiotics, also the same way, resolution and non-resolution to surgery. So when we are coming to the end of the systemic antibiotics, so we have found out that this the selection of an antibiotic should be made on based on various factors other than the empirical decisions made by the clinician. Therefore, the clinician must integrate the history of patient's disease, clinical signs and symptoms, and the results of radiographic examinations and possibly microbiological sampling to determine the course of periodontal therapy. So the clinician must take the final decision with the patient, and risk and benefits concerning antibiotics as adjuncts to periodontal therapy should be discussed with the patient before antibiotics are used. So then coming to local drug delivery, several controlled release delivery systems have been developed to deposit antimicrobials directly into the periodontal pocket and maintain effective concentrations of drug for an extended period. When they are administered adjunctively with SRP, which is generally considered by the professional community to be the best approach, we have three locally delivered controlled release antimicrobial products which are available in US. They are a chlorhexidine containing chip or periochip, a doxycycline gel or atrodox, and minocycline microspheres or arrestin. So coming to the details of each, coming to the chlorhexidine chip, which is a small chip that you can see in the picture, that is contains 2.5 milligram of the active ingredient of chlorhexidine gluconate, and which is resorbable biodegradable matrix of hydrolyzed gelatin that is cross-linked with glutaraldehyde and packaged in individual foil containers. You can see in the picture A there is a chip of 2.5 mg active ingredient chlorhexidine. So it can be taken out with the tweezer and or the artery forceps, and it can be placed inside the pocket. So the chip has been reported to release chlorhexidine into the gingival crevicular fluid over 7 to 10 days. Since it is biodegradable and does not require removal, but dental flows should be avoided for at least 10 days to avoid dislodging it. So there is chlorhexidine chip. Coming to doxycycline gel, this product is a viscous liquid of 500 mg which contains 50 mg of doxycycline hyclate. So it is a subgingival controlled release delivery product composed of a two syringe mixing system. So it can be mixed outside, and then this is used by injecting the mixed contents of two syringes directly into the pocket. You can see in this picture it is being mixed outside and can be injected into the periodontal pocket. So, doxycycline is a broad spectrum antibiotics, and it is bacteriostatic, inhibiting bacterial protein synthesis by interfering with transfer RNA and messenger RNA at the ribosome. The gel has been reported to release doxycycline in the GCF over 7 days. So this is indicated for the treatment of chronic adult periodontitis or for a gain in clinical attachment, reduction in probing depth, and reduction of bleeding on probing. Coming to the minocycline microspheres, it is a subgingival controlled release delivery system containing the antibiotic minocycline hydrochloride, which is incorporated into a bioresorbable polymer in unit dose cartridges. So each cartridge that delivers minocycline hydrochloride equivalent to 1 milligram of minocycline freebase. So you can see in this picture that it is indicated as an adjunct to SRP for the reduction of pocket depth in patients with adult periodontitis. So they are packaged into unit dose cartridges. Then they are used by injecting the cartridge contents directly with a syringe into the periodontal pocket. So, but patients should avoid hard or sticky foods at the treated teeth for at least 1 week and interproximal cleaning devices for about 10 days. And also it is biodegradable and surely doesn't require removal of the material. So again, it is belongs to the tetracycline class of antibiotics and has a broad spectrum of activity with bacteriostatic. Antimicrobial activity results from inhibition of protein synthesis. So coming to the other products, there is non-US locally delivered controlled release microbials. So these products typically use antimicrobial agents that were discussed earlier for US products and which is available in other countries. So coming to chlorhexidine based products, we have Periocol CG and Closite. So Periocol CG, there is a chip same like chlorhexidine chip that is designed as a collagen matrix into which chlorhexidine gluconate of 2.5 milligram is incorporated from a 20% chlorhexidine solution, that is its active ingredient. So this chip can be designed for is designed for insertion into the periodontal pocket and which resorbs after 30 days, but its coronal edge will degrade within 10 days. So coming to closed side, which is sanding gel consisting of a saccharide polymer as a three-dimensional mesh, which contains 1.5 percentage of fluorescein in 0.5 ml of gel, which is injected into the periodontal pocket. So this is sterilized by gamma radiation, and this is individually packed for delivery in 0.25 pre-filled syringes with a blunt end. So this gel contains two types of chlorhexidine. There is a slow release chlorhexidine, there is 0.5 percentage, and a rapid release chlorhexidine of 1 percentage. So this gel is retained within the pocket and is not easily dislodged by GCF or saliva. so which disappears from the pocket in 10 to 30 days and is reported to achieve a chlorhexidine concentration in GCF more than 100 mg per ml for an average of 6 to 9 days for the maximum concentration. So you can see that in the picture it is the closed packaging is being shown and the saline gel with chlorhexidine is inserted into the periodontal pocket in the right diagram. So coming to the tetracycline based products, we have Periocol TZ and Periodontal plus AP. So coming to Periocol CB, there contains fish type 1 collagen. There is approximately 25 milligram impregnated with 2 milligram of tetracycline hydrochloride, which is sterilized by gamma radiation, so which releases tetracycline in vitro for 8 to 10 days. So a periodontal dressing should be placed to avoid dislodging the fibers. You can see in the picture that it is arranged, packaged in an individual vial. So it is indicated for the treatment of adult periodontitis as an adjunct to SRP for pockets more than 5 milligram, 5 mm deep, and it can be administered every 3 months. So this can be moistened with saline and placed into the periodontal pocket to the depth of the pocket base. So they are biodegradable, so do not have to be get removed. Okay. So coming to the periodontal plus AB, there is also a bioresorbable tetracycline fiber. It is a 25 milligram of pure fibrillar collagen evenly impregnated with approximately 2 milligram of tetracycline hydrochloride. So this fiber are packaged as a strip containing 4 individually packed and separatable sterile product packs. So this degrades in the periodontal pocket within 7 days. So this can be retained with the periodontal dressing again or covered with a dental adhesive or for 10 days. Coming to doxycycline based products, under that Ligosan slow release, uh, it is 14% resorbable doxycycline cell gel for periodontal application provided in a laminate pouch and stored under refrigeration, which contains 1 to 4, 8, 10 or 16 single application cylinder cartridges, each containing 260 milligram of Ligosan slow release. So it is used by inserting the cartridge into the cochlear gun and opening the spray nozzle and then discharging gel into the bottom of the pocket. You can see that this is the box, the laminated box, and there is laminate pouch, and it is a cochlear gun tip is there. You can fix it to that, and then it is released into the pocket area. So this product is used by inserting the cartridge into the gun, opening the spray nozzle and then discharging. So this profile was studied in 20 patients actually. They found out that like, increased concentration reached by 12 days. So mechanical hygiene in the area should be avoided, same as like before, like it should be avoided for at least 7 days. Coming to the rationale for local drug delivery and control release. So, as we know, there is periodontitis is a multifactorial disease. So, the first requirement is a susceptible host, largely due to genetics and are not modifiable. And another non-modifiable risk factor is age. So, disease risks that can be modified include pathogenic oral microorganisms and behavioral or environmental factors. So many strategies have been used to deliver antimicrobial agents to the periodontal pocket of affected diseases. So none of these strategies has proved as effective as this controlled release antimicrobial. So there is a need of this local drug delivery. So high antimicrobial concentrations in the GCF as a result of doctor delivery could help to reach the infected sites with the root or tissue. So this like all the if high concentration of antimicrobial drug are desired in the then in the periodontal pocket, systemic delivery is not the appropriate therapy. And also this antimicrobials delivered to the pocket that is not under controlled release are getting easily washed off by GCF, rapidly reducing the concentration of drug locally into the pocket area. So that is it can be clearly seen with the schematic diagram. You can see that the first that is showing with the systemic administration. So there is orally taken, it is getting absorbed to the gastrointestinal tract, then transported by the portal pathway to the liver, and then enters the circulatory system from which the drug exits the vasculature into the periodontal pocket. So there is drug is quickly eliminated from the pocket into the oral cavity by the copious flow of GCF. But in the other picture, you can see that it is locally administered drugs. There is in controlled release. It is administered into the periodontal pocket where it remains until it degrades. So there is continuously releasing drug into the GCF over time. So this may be effective against plaque bacteria that have invaded the surrounding periodontal tissues. So when coming to the benefits of this droppal delivery, which include decreased systemic off-target effects and a decreased risk for promoting microbial resistance. So coming to indications of LDD, indication patients with grade A or B periodontitis, that is with mild periodontitis and not with complex type of periodontal pocket, and sites with the non-responsive to treatment or the sites with where surgery cannot be done. So in that areas also LDD can be indicated, and with localized persistent recurrent mild pocket depth. So if it is localized area, not a generalized area, you can try with this LDD. And also with the case of grade 2 furcation involvement where one wall is completely loose, another wall, so in that case the maintenance won't be that much proper, so we can have a local drug delivery in this case. But what are the contraindications where there is grade C periodontitis? There is advanced type of periodontitis with complex type of pocket and advanced periodontitis. It is not recommended, and active periodontal destruction is there. So we can go for surgery instead of LDD, and hypersensitivity to any of the components of LDD or as a replacement to SRP or surgery or systemic antibiotics, it is not indicated. And if it is susceptible to infective endocarditis, that is to avoid the risk of bacteremia. So there is also it is contraindicated. Coming to advantages of LDD, high concentration can be achieved when it is controlled release into the site of infection, and also suitable for agents which can be given systemically. For example, chlorhexidine that cannot be given systemically, so that is the advantage. And also the superinfection and drug resistance will be rare in case of LDD, and there will be improved patient compliance since it is not being taken orally, and there will be reduction in total drug usage, frequency of drug administration. So coming to disadvantages, definitely it should be given by a dental professional, so which is time consuming and which requires special effort also. But limited, there will be limited action for the extra or pocket oral service. That means other areas it won't be effective, only into the pocket. So there are chances to get reinfection from the other areas. So it may not have complete access to the deeper pockets or furcation. So these are the disadvantages. So coming to the benefits, so when we list out the benefits of local drug delivery, we should that is we can stress more on concentration achievable locally is higher, and better patient compliance. Then GCF concentration greater than serum levels. Delivery is localized, so which reduces systemic effects, and definitely no systemic drug resistance. So coming to the conclusion, evidence is strong that adjunctive, systemically and locally drug delivered controlled release antimicrobials make SRP significantly more effective and have a non-safety profile. So based on available data, when these agents are used routinely as adjuncts to SRP as indicated as part of initial periodontal treatment or maintenance therapy, clinicians can expect a significantly greater mean reduction in popping depth compared with SRP alone. So the practitioner should evaluate the evidence and suggested treatment that has the greatest probability for success based on current data. Okay, thank you for today. Have a nice day.